Hi guys, and welcome back to another Anesthesia step-by-step tutorial. Today we'll be talking about hypotension. We return to our operating theatre, where you've anaesthetised your patient without any problems at all, and as always the surgeon is cracking on with their operation. All appears well, but then the monitor starts alarming, alerting you to a worryingly low blood pressure. What do? Well, you may be noticing a trend by now, because the first thing we're going to do is set the oxygen to 100% and the flows nice and high, to ensure that we're delivering enough oxygen to our patient. Low blood pressure usually implies low delivery of oxygen to the vital organs, so we can offset that at least a little by ensuring the patient is receiving as much oxygen as possible while we diagnose and fix the problem. Just be sure to double check your vapour concentration isn't too high as you increase the flow rate. Next, we check our breathing circuit for obstructions and disconnections before moving on to the airway. Check its position and the capnogram to rule out any airway obstruction. The capnogram will also give you an idea of cardiac output. If the square wave is flatter than usual, that suggests a very low perfusion state, as the CO2 is not being delivered to the lungs effectively. Breathing comes next, and we're going to rapidly assess for symmetrical air entry, respiratory rate if the patient's breathing spontaneously, and any relevant sounds such as wheeze that may indicate anaphylaxis. The saturations on the monitor will also give you an idea of peripheral perfusion, and the tidal volumes and end tidal CO2 will give you an idea as to whether intrathoracic pressure is an issue. Flip the circuit off the ventilator and onto the bag in a mechanically ventilated patient, and feel for the pressure inside the chest. So high pressure in the thorax compresses the great vessels around the heart and can cause dangerously low cardiac output. Circulation is next, and we're looking at the heart rate and rhythm first. A sudden change in the heart rate or rhythm, such as in the case of fast atrial fibrillation or SVT, may be the primary cause of the low blood pressure, while a sinus tachycardia is likely to be a compensatory reflex for a low blood pressure caused by something else. A sinus bradycardia can also cause low pressure, so if the heart rate is low, consider an antimuscarinic such as glycopyrrolate or atropine. A dose of vasopressor from your emergency drugs tray is rarely a bad idea at this point, as well as positioning the patient head down to facilitate venous return to the heart. A fluid bolus of 250 ml will also help identify if hypovolemia is the problem, whilst helping to restore circulating volume. Depth of anaesthesia comes next. An overly sedated or analgesed patient will have a low blood pressure, and this is often the cause of hypotension intraoperatively. Classically, there will be a pause in the operation, and the lack of surgical stimulation will mean the amount of anaesthetic on board is sufficient to drop the patient's blood pressure. You can either reduce the depth slightly, or politely encourage your surgical colleagues to get a move on. Sixth is surgical causes. Have a quick look over the drape just to make sure you're not missing an obvious surgical cause of hypotension that may require urgent attention. Usually by this point the cause of the issue will be clear, but some other causes to consider and rule out are listed here. As always, make sure you're calling for help from senior colleagues at an appropriate time, and refer to the Quick Reference Handbook to make sure you're not missing anything.